are at least somewhat familiar with OCD, or the so-called Obsessive Compulsive Disorder. But there's so much more than meets the eye when it comes to the set of challenges officially called obsessive compulsive and related issues. In this class, we're going to look at how trauma plays a role, at least in some of them. And we're also going to share some successes we've had with the gentle trauma release method in this respect. Enjoy the class. Many people are familiar with the obsessive compulsive disorder, if nothing else than because of the many fictional characters portrayed in literature or TV shows. There's Detective Monk, who is absolutely brilliant in his own right, but who can get utterly distracted if things are not just so. Be it books and the way they're arranged on a shelf or a bedside table, be it a picture on the wall that is 1 millimeter off to one side. He has to touch every parking meter that he walks by, and things have to be rounded to 10 or 100 in order for him not to feel distressed. Then there's Monica Geller from the Friends show, who has a hard time stopping herself from cleaning, being a bit fixated on cleanliness and order. In fact, cleaning makes her feel good. Now, Monica Geller would probably not meet the criteria of the OCD diagnosis, and this video will help you see why. OCD, the Obsessive Compulsive Disorder, is actually part of a bigger category, officially called Obsessive Compulsive and Related Disorders. This category includes challenges such as OCD itself, body dysmorphia, the hoarding disorder, compulsive hair pulling, or skin picking disorder. If you're not a therapist or a psychiatrist, you probably won't come across someone who has a full-blown case of OCD. Your clients might have a milder or slightly different version of a disorder that doesn't meet the official diagnostic criteria, but that doesn't mean that the person isn't suffering as a result of it or that they don't need help. We see this quite often in the coaching practice. As an example, our clients will not need an emergency intervention or hospitalization because of their issues, and they can still function in life, but their life is very far from being optimal, and they do suffer as a result of these issues, and their life is way harder than it has to be. For instance, one of our GTR graduates recently had a client who just couldn't stop obsessively thinking about her ex-boyfriend, and this went on for decades. She has been married for a long time, and a day didn't pass that her thoughts wouldn't wander to her ex in an obsessive way. Let's first look at OCD itself, the Obsessive Compulsive Disorder, the way the Diagnostic and Statistical Manual defines it at this point. OCD has two main features. They are obsessions and compulsions. And to be officially diagnosed with OCD, you have to have one or the other or both. But let's look at what obsessions and compulsions actually mean in psychological terms. Obsessions are recurrent and persistent thoughts, images, or urges that are intrusive and unwanted by the person experiencing them, and they cause this person marked anxiety and distress. And this is because these thoughts, images, and urges are usually disturbing in some way or inappropriate, and the person is not able to control them. There are many different kinds of obsessions based on the quote-unquote theme of these recurrent thoughts, images, and urges. As an example, someone might experience constant, recurring, intrusive thoughts that have to do with causing harm to others or oneself. In other words, harm-themed obsessions. the harm is inflicted in a very specific ways. For example, thoughts that one would poison their spouse and children and parents, or that when driving, one would hit the pedestrians along the way. These can actually be not just thoughts, but also images. For instance, constantly imagining that one is strangling their mother or husband. Now, even though people with OCD very rarely act on these thoughts, you can imagine how debilitating it has to be to live with intrusive images or thoughts like these, because there's no way to control them or to make them stop. What I have encountered in my coaching practice is also recurring dreams that my clients had with this flavor. For example, a woman periodically dreaming that her husband was a red pill and that she was trying to push that red pill down the toilet. She was extremely distressed by that dream, and over time, it became a nightmare. Also, bear in mind that sometimes a client might tell you that they dream of something like I just told you, when in reality, they experience these obsessive thoughts or images in broad daylight, but they're just too embarrassed to tell you that they're constantly thinking of causing harm to someone close to them. Then there are symmetry obsessions, where the person has an obsessive need for symmetry. Books on the shelves have to be arranged in a certain way, or the food on their plate has to be arranged in a certain way. There are contamination obsessions. These have to do with contracting an illness or coming into contact with germs or spreading germs. There are religious obsessions. For example, recurring thoughts about how something one did or thought is a sin and how one will be punished for it. And then there are also sexuality obsessions, thoughts about sexuality and sexual acts in the most inappropriate, violent, and or illegal forms. Now, enter the second part of the equation, the compulsions. People who experience obsessions, no matter what kind, tend to perform certain very specific behaviors to help them dissolve the extremely negative emotions caused by their obsessions. For example, anxiety, discomfort, and fear. There are several categories of compulsive behaviors that people suffering from OCD tend to engage in. There's cleaning, such as lengthy hand washing or showering, repeating, checking, so repeatedly checking, for example, if the stove or the oven are turned off or if the locks are locked properly. Then there's ordering and or arranging in certain patterns, and counting. Now, the reason why these behaviors are called compulsions is because people who suffer from OCD don't really want to perform these acts repeatedly. They don't necessarily make sense to them either. And they can often recognize how pointless these compulsive behaviors such as checking and rechecking are. But they feel like they can't help themselves, like they have no control over these acts. In OCD, the compulsions have the form of a ritual, in that the behavior has to happen in a very specific way and exactly that way every time. For instance, the compulsive action has to be repeated an exact number of times or for an exact duration of time or in a specific order. In other words, there are quite rigid rules to these compulsive behaviors, these rituals really. The ritual can happen outwardly, for example, checking if the locks are locked 10 times exactly and doing so in a specific order, or they can happen inwardly, mentally, if you will, where a person can say certain words over and over again in their mind. OCD-like traits become a problem when the thoughts and images become intrusive and recurrent and most importantly, once they start causing high levels of anxiety and emotional distress. Then the compulsive behaviors performed to counteract those obsessions have to significantly interfere with one's life in that they're very time and or energy consuming to the point that one finds it harder to function in the different areas of life, professional, social, or personal. And this, by the way, is the reason why Monica Geller from the Friends show would not get an OCD diagnosis. Despite her little obsessions with order and cleaning, she can easily function in life. Having said that, just because someone doesn't meet the often quite rigid diagnostic criteria of different mental health issues, that in itself doesn't mean that they're well. And it definitely doesn't mean that they don't need help. Let's now look at a case study where the client's challenge had a lot of OCD-like traits and how the GTR method was able to induce a beautiful healing. It's a great example of how your client can suffer from a milder version of a certain mental health challenge, one which wouldn't necessarily lead to an official diagnosis, and yet their life can be far from ideal because of that challenge. This is the client I mentioned earlier in this video class. A lady, let's call her Annette, worked with one of our GTR practitioners. Annette has been married for many years, but her mind kept flooding her with thoughts and images of her ex-boyfriend from a long time ago. In fact, even though they broke up decades ago and haven't been in contact since, she would still think about him in the present tense and talk about him in the present tense, as though he was still part of her everyday life. In fact, whenever she got distressed, she would repeat his name to herself over and over again to calm herself down. Now, if you recognize a little compulsive ritual in this behavior, you're right. But the compulsive behaviors didn't end there. Annette would also stalk her ex-boyfriend online, Googling his name and using social media to get more information on him. She would ask their mutual friends about him in order to learn more. Especially, her mission seemed to be to find out if he still spoke about her and if he still thought of her. And this went on daily for decades. This could be your typical coaching client, and without at least some understanding of trauma, and without a reliable tool such as the GTR method able to release trauma from your client's body, the ability to support her would be rather limited. The GTR practitioner who worked with Annette was able to get her to a place where one day she realized that it's been weeks now that she hasn't thought of her ex. And this time, it was just because the GTR practitioner asked her about him. Today, Annette no longer checks online to find news about him. She doesn't recite his name to herself like a little prayer. And she had some huge realizations about the truth of this past relationship. Realizations that made it possible for her to move on. The bottom line is, a handful of GTR sessions eliminated an obsession that lasted for decades. Now, you might ask yourself, but what does an obsession like this have to do with trauma? Let's explore. Research tells us that OCD often occurs simultaneously with PTSD. Granted, OCD is a neurobiological disorder, meaning technically not caused by events in a person's life. However, it may well be possible that, just as in the case of many other mental health challenges, stress, let alone stress in the form of trauma, can either trigger or exacerbate certain inborn predispositions. For instance, if someone was born with an OCD predisposition, then A traumatic event or a series of them could create the right environment for their OCD to start expressing itself or for worsening of the already existing OCD. To give you an example, one of the fairly common symptoms of PTSD is hypervigilance, and one can imagine how, say, a veteran of war carrying trauma in their system might gravitate towards OCD-like tendencies, say checking and rechecking if the doors and windows are closed because they don't feel safe in their home, even once they're back from the battlefield. Or checking and rechecking their guns, especially if there is a genetic OCD predisposition to begin with. The constant flashbacks from the battlefield or the nightmares full of horrors, which are nothing less and nothing more than intrusive, recurrent thoughts or images, could easily lead to compulsive behaviors such as checking and rechecking. Now, recurrent intrusive thoughts causing extreme distress and anxiety are in fact a feature that both PTSD and OCD have in common. They are one of the main diagnostical criteria in both of these diagnoses. The difference is that in PTSD, the person would typically display avoidance behaviors to resolve the tension and the distress caused by these thoughts. For example, they would avoid certain places, situations, or really anything that could remind them of the traumas that they've been through. But in OCD, the person would engage in compulsive behaviors instead to deal with their emotional distress. Take the case of a woman raped at the workplace. After this terrible experience, she quit her job and she managed to find a new one, but she can't seem to stop the compulsion to shower many times a day. And it's really the only thing that allows her to feel like she can't feel the perpetrator's touch on her body and smell his breath. It helps her get rid of the feeling that she's still somehow dirty. The showering ritual has specific rules, and she can only feel clean emotionally if she follows them to the T. Otherwise, she has to start over. In a nutshell, there seems to be trauma-related OCD, where a person develops OCD after experiencing a traumatic event or a series of traumatic events. This means that if we manage to identify those events, clear and collapse them, the OCD-like symptoms will go away. Let's look at how this hypothesis worked in Annette's case, the client who couldn't stop fixating and obsessing over her ex. When Annette started working with her GTR practitioner, it became clear that her life was marked by not feeling good about herself, and this had nothing to do with her ex. She grew up believing that she was mean and bossy, and these characteristics were constantly reinforced by her family members, leading to toxic shame and loss of self-worthiness. As it turned out, Annette felt that her ex-boyfriend was the only person in her life who knew the real her, the only person who knew that Annette was a nice person instead of the mean, bossy woman that her whole family saw her as. When they broke up, Annette was devastated, not only because of the heartbreak, but also because now she lost the only person who actually believed her to be nice and good. You can probably see how and why the compulsive behavior that consisted of repeating his name to herself, like a little prayer, calmed her down. It is almost as if Annette was mentally invoking him back into her life to reaffirm to herself that she wasn't a mean person, and to dissolve the stress around the intrusive, recurrent thoughts invading her mind, telling her that she was mean and bossy, and that's exactly who she was. In that respect, it also makes sense why a part of her felt that if only she could find proof of him still loving her, that this would be another confirmation that she was a good person. He and only he knew the real her after all. This is why she kept stalking him. Sometimes mainstream psychology describes people with OCD as prone to magical thinking, as if the compulsive behavior, such as washing or checking, has some sort of magical power to unspell the source of their distress. But as you can see, if one looks at OCD-like challenges in the light of trauma, things do make sense. Annette was suffering from toxic shame and unworthiness installed in her growing up, and she found a way, albeit a dysfunctional one, to stop feeling this badly about herself, at least from time to time. Annette had a few GTR sessions with her practitioner. They cleared some core traumatic memories from Annette's past, none of which had to do with the actual relationship with the boyfriend. However, because Annette's trauma was cleared, Annette's symptoms went away. In her case, the OCD-like behaviors. And this is because the root cause of her issues, meaning the traumatic events from her past, were taken care of, neutralized, and collapsed through the GTR method. Now, an interesting question might be, but how is this different from the mainstream approach to OCD? The mainstream status quo of OCD treatment is the following. There's medication, especially antidepressants, but the results are not impressive. And then there's something called the exposure and response prevention therapy. It's a bit of a mouthful. This is probably the best that the mainstream can offer to people suffering from OCD at this point. This therapy is based on exposing the person suffering from OCD to the source of their anxiety. For example, if someone has contamination-based OCD, then this would be exposing them to germs or dirt, be it in a guided visualization, and then eventually in real life, for example, by having them touch a toilet seat in a public bathroom or have them sit on a dirty floor of a public bathroom. And then preventing them from engaging in what would be their usual compulsive behavior. For example, they would be asked not to wash their hands for several hours after touching that toilet seat, with the idea being to show them that if they allow for enough time, usually several hours, their anxiety created by their obsessive thoughts will pass on its own without them having to resolve to the compulsive behaviors. For example, the lengthy ritualized hand washing. The exposure and response prevention therapy can also go above and beyond just the work done in a session like this, and it can include some quote-unquote homework. The therapist can, for example, drive the patient with, say, contamination OCD to a spot where there's a dead dog lying on the road. And the therapist will then ask the patient to approach and smell the corpse of the dead animal or poke it with a small stick. Then the homework becomes to put that stick into the patient's pocket and have them touch it frequently throughout the days to come. Research tells us that although some patients refuse this kind of treatment and drop out very early, those who stay see some reduction in symptoms. But even so, even with the exposure and response prevention therapy, OCD doesn't seem to go away completely, and the person is still left with at least some degree of obsessions and compulsions. The current status quo in mainstream psychology, psychiatry, and therapy is such that the role of trauma in many mental health challenges, including the obsessive compulsive and related disorders, is either overlooked or underestimated because really it's under-researched, let alone the fact that the mainstream doesn't seem to be able to help someone release trauma reliably and long-term. Now, just to be clear, we're not saying that there has to be trauma behind every case of OCD. What we are saying here is that at least some of the cases of OCD can be triggered by trauma, in which case, if we clear and collapse the core traumatic events, the core traumatic memories behind the OCD issues, then the OCD symptoms will go away. In other words, trauma needs to leave the client's system before we see any real results and healing, just like in the case of Annette. Body dysmorphia is another challenge that belongs under the umbrella of obsessive compulsive and related disorders, and we've had some promising results here with GTR as well. But allow me to first tell you about what exactly body dysmorphia is. That way you'll be able to better appreciate the healing story offered in this class. First of all, body dysmorphia has nothing to do with food intake. It's not an eating disorder. But because it belongs to the category of obsessive compulsive and related disorders, it is characterized by pretty much the same two main features as OCD itself, aka obsessions and compulsions. In the case of body dysmorphia, the obsessions, i.e. these recurrent, intrusive, persistent thoughts and images, have to do with one or more parts of the body, where the person perceives a specific part of their body to be ugly, disfigured, disproportionate, just severely flawed and defected in some way. It is important to note that this flaw is either completely imagined or just extremely blown out of proportion. For example, someone might have a tiny little birthmark on their face, perhaps a tiny spot, so small that no one else would actually notice it. But the person suffering from body dysmorphia perceives it as huge, almost covering their whole face, extremely ugly or hideous. The perceived flaw in appearance can have to do with almost any body part. Body dysmorphia is characterized by distorted perceptions of one's own body and appearance, and by a constant, persistent preoccupation with these perceived body flaws. That goes way above and beyond the common concerns that other people who don't suffer from body dysmorphia can have about their appearance. We're talking about intense preoccupation that leads to extreme emotional distress and pain. And just like in the case of pure OCD, the person suffering from body dysmorphia will often turn to compulsive behaviors to dissolve their extreme emotional distress, to counteract their obsessions. In other words, they will turn to ritual-like acts in order to feel better, at least temporarily. And this can be compulsive mirror checking themselves in the mirror for very long periods of time and usually hoping that the perceived flaw or defect will look different this time around. There can be compulsive grooming and camouflaging. Usually they try to somehow hide or conceal the flawed part, say with makeup, clothing, or covering a part of their face with hair so no one can see the flaw. Or there can be compulsive reassurance seeking, and this usually has to do with seeking reassurance from family and friends. However, these days with social media, it's possible to get a temporary fix, if you will, by frequently posting flattering images of oneself, because it's likely that praise and compliments will follow. This is how the social media culture works usually. I stroke you, you stroke me. And that's another way that people with body dysmorphia get that temporary reassurance. And this has nothing to do with vanity, which is what it can often look like on the surface if you see someone constantly posting pictures of themselves on social media. One might think that they're seeking attention or they're being vain and self centered. But for a person suffering from body dysmorphia, this can really be that compulsive ritual, that compulsive behavior to dissolve the extreme distress and anxiety caused by the obsessive thoughts about their body defects and flaws. In fact, they can feel so badly about themselves, so repulsed by themselves, that they will engage in avoidance behaviors too, meaning they will stop going places and avoid usual activities out of the fear that their perceived flaws might be spotted or uncovered and that others will now be repulsed by them. Currently, body dysmorphia is treated with antidepressants, although a higher dosage is required than in pure OCD. Of course, you need to continue taking them. And then there's CBT, cognitive behavioral therapy, that tries to change the person's perceptions of their body and the flaws of their body and prevent them from engaging in the compulsive behaviors like checking and camouflaging. This, however, is once again that exposure and response prevention therapy that we talked about in relation to pure OCD, which might also not be optimal, but at the moment, that's what the mainstream has to offer. People suffering from body dysmorphia usually turn to plastic surgery, which of course doesn't solve anything because the root cause of the problem wasn't dealt with. This is why we're pleased to see that the GTR method can be of help here, provided that the body dysmorphia is trauma-related, that is, triggered by distressing, traumatic events from a person's past.
I had a client who revealed to me, confided in me that she had body dysmorphia. Body dysmorphia, of course, is a mental illness that really results in someone heavily focusing on flaws that they perceive, not necessarily what everyone else perceives, but that they perceive about themselves. And it can be very much an obsessive, compulsive type of thinking about themselves. So this client, we began to discuss that, and there were definitely some I guess what we would call in gentle trauma release are some indicators that trauma could be present. Even though it's defined as body dysmorphia and a mental illness, there were still those indicators present that led me to believe that there may be something else here. So the biggest, I would have to say the biggest one for me was when this client said, I wasn't always like this. This really has only been since. And that's where we started. And we started to explore what actually was happening at that time. What happened that made you feel that I'm no longer like that anymore? What happened? And it was during that time that we were able to identify traumatic memories, events that occurred around that time that she started to have these obsessive of thoughts, and being excessively preoccupied is probably the word that comes to mind with what she perceived as her flaws. The other indicators that really helped me to identify that there really was trauma present was in gentle trauma release, we would say that to identify trauma, it would be memories that prove to be intrusive, that maybe are fragmented and vivid. And these were all present. All of these three aspects of her memories and her thoughts, these all three of these were present. And it was also the emotional intensity. When these specific memories, and actually when this client went back to that time, there were things that she was able to recall that she would not have been able to identify readily. It wasn't readily available to her when we first started talking. It was almost as if when we went back to that time, other things came up that she didn't she didn't remember had actually happened. So we were able to do the basic recipe, utilize the basic recipe to neutralize and clear those traumatic memories. We also did the emotional release recipe to help, to promote a calmness and to provide some relief from the emotional intensity that she was feeling. And also as a tool to kind of have in her pocket to deal with her emotions on a daily basis. We also worked with the Tame the Critic method and elicited those negative beliefs that she had about herself, and were able to turn them around. And in doing that, we were able to really bring her to a point where she could believe them, where she could look at them differently, and almost to the point where the beliefs just collapsed and were developed into much more healthier, beautiful, loving, and supportive beliefs. And another protocol that we utilized towards the end of our work together was the positivity recipe. And I'm happy to say that this client no longer has body dysmorphia. She has a very healthy body image. She even laughs now when she thinks about the thoughts that she had about her body and how intrusive they were and how vivid they were. She even laughs about that now and feels like it's almost like it was a movie. Before gentle trauma release, this client had a real perceived a part of her body as a huge flaw. And it was her legs. She felt her legs were too long. She used the word too skinny, and it looked awkward to her. She felt distorted, that the pieces didn't match up. The top didn't match with the bottom. It stood out. She was very active, and this was affecting her in those activities. At one point, she talks about how she loved Lululemon clothing and then refused outright to wear any of it when it came to the leggings and the shorts. She played many sports where the short shorts were what was worn. To the practices as well as to the games. It sort of the uniform, and that felt horrible for her. She also there were times when she would have to dress formally and wear a dress or skirt, and those times created very, very much anxiety, and just devastation and sadness. She would, if there was an event coming up that she knew she would have to wear any of these sorts of things, she would be stressed, she would be anxious, she wouldn't sleep, she would detach, she would get very sad, then she'd beat up on herself, and then she would feel guilty about it. It was just this never-ending cycle, and it continuously repeated because there was always another event. Now she still plays all of the sports, but she's completely comfortable in those short shorts. She's back to loving her Lululemon leggings, and gets excited now whenever they launch new designs. It's actually, it wasn't that long ago, actually. It was just a few weeks ago that they had this event, and she's actually a school student. They had this event at school, a formal day, and she wore the dress that she wanted to wear, and she felt beautiful in it. She looked in the mirror, she was happy, she was excited. She doesn't see those flaws that she's seen before. She doesn't see any flaws. And she also doesn't have any obsessive thoughts. She doesn't feel like she's always having to think about the same thing, or that it keeps repeating, or that she has no control over when that thought starts and how to release it. She really, it's a huge difference. She's so very confident, and it's wonderful to see.
Let's look at one final scenario. This one is to demonstrate how the GTR method can be helpful even with very difficult challenges that the mainstream psychology is only beginning to understand. It's a topic that is still a bit taboo, but nonetheless so important to talk about, and it's the phenomenon of skin cutting, where a person would cut their skin to deliberately cause damage to themselves, but without the intention to commit suicide. Cutting is not a completely rare occurrence, which is why it has been recently added to the Registry of Mental Health Disorders, to the Diagnostic and Statistical Manual. And they put it under a broader umbrella of the non-suicidal self-injury diagnosis. Now, skin cutting is a fairly common feature of the borderline personality. However, not all people who engage in skin cutting have also the borderline personality disorder. Psychology is only beginning to understand the non-suicidal self-injury diagnosis, and many question marks are still present. Because of that, non-suicidal self-injury, for now, belongs to a category of disorders that need further study. In other words, psychologists don't know enough as to put it in one of the existing categories, for example, anxiety disorders, eating disorders, or personality disorders. But this is a class on obsessive compulsive issues, and the reason we included skin cutting into this class is because we suspect that at least some cases of cutting involve the two main features of obsessive compulsive issues, that is, obsessions and compulsions. The compulsive part, the skin cutting, is relatively clear to understand. Based on the psychological interviews conducted with the people who engage in skin cutting, it seems to be clear that cutting brings them relief from a very acute and intense emotional distress. But apart from the relief, as you now know, compulsive behaviors are also characterized by the ritualistic nature of the compulsive behavior, where the person has a very good sense of how the ritual has to unfold and what needs to happen in order for it to be complete. In the case of skin cutting, people often report that it's seeing the blood that brings them ultimate relief, and that's when they stop. They would say something like, "And then I saw the red, I felt better and I stopped cutting." In other words, it's not just any behavior they engage in to achieve the relief and the release of emotional distress. It happens very specifically through skin cutting, and it's complete when they see the blood coming out of their wounds. In this respect, it's quite similar to compulsive skin picking or compulsive hair pulling, both of which already officially belong to the category of obsessive compulsive and related disorders. The obsessive part, then, are the intrusive thoughts or urges to cut one's skin. And it's the tension caused by these urges and thoughts that is resolved through the cutting itself. Now, in GTR, we hypothesize, what if there is a deeper layer, a layer beneath the obsessive, intrusive thoughts urging a person to, say, cut their skin? What if there are, at least in some cases, specific traumatic events in a person's past? And what if that extreme distress caused by those traumatic events trigger their OCD traits? Some of these OCD urges, such as skin cutting. And what if there is also an inner critic component, which is so very common in people with complex trauma? And what if some of those obsessive thoughts are very negative, self-loathing thoughts undermining the person's worth, self-esteem, that somehow translate in the brain as thoughts, images, and urges that take a very specific ritual-like form, such as skin cutting? If this hypothesis is true, then collapsing the past traumatic events should ease those OCD-like urges, compelling a person to cut their skin. And this is exactly what happened when one of our GTR practitioners worked with a client who has been cutting her skin for decades.
You look at a lot of tribal rituals. You will find it, especially like Africa and I think in the Indonesian islands, you'll find that especially when there's a death or anything like that, that they do the cutting quite often. They scar themselves.
And what is the purpose of that? Do you know?
I think it was originally a way to deal with the pain, to release the pain in their customs. Mm-hmm. I'm not sure, but it makes sense when you think about what causes a person to start cutting. And I know that was the case with my client. She started cutting clear back when she was in school, and nobody realized it for many years that she was doing it. She was hiding it very well.
Yes. And so this client was cutting for decades, really, the one that you worked with.
Yeah, she's in her 40s and she's been cutting since she was in her teens.
And when she came to you, it was at a point that during her more difficult periods, she would cut daily, and she would also carve words into her skin.
Yeah, recently, a few months ago, she tried to commit suicide. And when she was, right before that, when she was really brittle, she started trying to carve actual words into her arm and her chest. And very, very difficult situation.
Yes, and that's where you stepped in. And I actually have a quote that she sent to you saying, I honestly think you, Pat, and I are doing more to cure my issues than I'm getting in therapy. The therapist is helping me with coping skills, which is great, but you're actually helping me get through and over the problems.
Yeah. Yeah.
Yeah.
It's been so effective, the GTR. It's just been unbelievable for her. Along with the coping skills that she has learned from her therapist, the two in combination have just worked really well for her. And she's doing quite well at the moment.
Okay. And because we've been consulting on this client of yours, here are some of the things that I remember as some of the extremely good results that you were able to guide her towards. The biggest one, obviously, is her handing over her razor blades.
Yes, that was a huge, huge moment for her when she gave those razor blades over to her husband, because she had been hiding those so that nobody could find them, so she would have access. And for her to make that breakthrough was just tremendous.
Yes. And just so everybody understands how huge it is, skin cutting has this compulsive elements. It's very much OCD like, meaning the person has this urge to cut for whatever reason, and the only way to resolve that tension, that distress, is specifically through the ritual. Be it cutting, for somebody else it might be skin picking or hair pulling, things like that. So the reason why I'm mentioning it is that it's a compulsion. They can't help it. So for you to get her to a place where she voluntarily hands over her razor blades, that's something that as far as I know, even therapy cannot accomplish.
No, and they say most of the time it's very difficult, even after treatment, for them to let go of that need to cut, because there's something about the sight of the blood that satisfies that need. The satisfaction was actually seeing the blood flow. It was like actively seeing that pain drain out.
And if I'm smiling, I just hope you know it's not because it's funny. It's because this is exactly what we're talking about in this lecture on OCD and similar issues. It's because it's a ritual. A ritual has specific rules, and that person knows how to conduct that ritual and when it's over and when it's complete. And so people who cut often say this very thing, that when I saw the blood, I knew it was complete and I felt better.
Yes.
Mm-hmm. Yeah. So handing over her razor blades, taking her from being suicidal, cutting every day and covering words into her skin to, okay, something is changing.
Yeah, absolutely. It's changing. Thank goodness.
Yes. And so how is she doing today? I mean, considering how big this is, we wouldn't expect things to change from one day to another. But considering what she had before therapy and other kinds of help, what do you see?
Well, she's been in therapy this whole time. She's seen her therapist at least once or twice a week. I'm very fortunate that the therapist is very open to working with my methods, our methods, the GTR method. She was going to refer her for EMDR in the beginning, the therapist was. And when I found that out, I reached out and said, that's incorporated into our GTR method. I think I can really help you even more so than what just EMDR would do. And so we started working, and it's just been such a success. The transformation has been amazing. And she's learned other coping skills, which have helped her as well from the therapist. But the combination of the two has pretty much eliminated the cutting, and she's a lot calmer. They've adjusted her medications, of course, in this process. But at the moment, she's in a really good place.
Thank you for sharing that, because I find that this is one of those things that are a bit taboo, and yet they're happening. And so we need to talk about them.
Absolutely. Yeah. Very hard subject to broach with people because they don't understand. They don't understand how a person could mutilate themselves in that manner.
Finally, there's still a lot of research needed to understand and efficiently treat OCD and related issues. On the bright side, at least some of these issues seem to be triggered and exacerbated by the past traumas from a person's life. And this means that de-traumatizing their system and targeting the root cause of these issues will lead to elimination or significant improvement of their OCD-like symptoms. And this is an absolutely wonderful piece of news. I hope this class gave you a lot of food for thought, and I hope it managed to open your eyes a little bit to what is possible. Until we connect the next time, goodbye.